everybody, and welcome to Chapter 3. Chapter 3 focuses on clinical assessment and diagnosis. In order to treat a disorder, we must first identify it, right? So we engage in clinical assessment, which is the evaluation and measurement of psychological, biological, and social factors in a person presenting with a psychological disorder. And when we say that presenting with a psychological disorder, that is clinical terminology. The patient is presenting with the following. And that's how we phrase it when we're going about identifying disorders. The diagnosis is the process of determining whether a presenting problem meets the established criteria of the DSM-5 for a specific psychological disorder. So the DSM-5 is basically the Bible of mental illness. It lists every mental illness, and within the listing of each mental illness, it lists symptomology criteria. It lists pretty much all possible symptomology that is demonstrated with a mental disorder, and it will give you instructions. It will say, here's a list of 10 symptoms. In order to be formally diagnosed, the individual must possess at least 6. Right, so clinical assessment and diagnosis are the identifying beginnings of mental disorder. Okay, the following I'm going to list are concepts that we use to make sure there's value to a clinician's assessment of mental illness. So let's talk about reliability. Reliability is the degree to which a measure is consistent, meaning if I have multiple people, separate raters, separate clinicians, trying to diagnose the same illness, can they use this tool and will they get the same conclusion? If they all get different conclusions, there's very little reliability. When it comes to diagnostic procedures, we need a high rate of reliability. That anybody can come in and use this tool, and if they are presented with the same person who presents with different symptomology, we will all come up with the same diagnosis. If we all come up with a different diagnosis, then our tool isn't very good. We have very low reliability. Next is validity, which is whether something measures what it is designed to measure. A good measure will have high predictive validity, and predictive validity means that your identification of the original diagnosis will provide a reliable idea of what's going to happen in the future. So for example, I use the example of bipolar disorder. If we have predictive validity of the diagnosis criteria, I should be able to say, I'm diagnosing you with bipolar disorder, and here's what you can expect to suffer from. High rates of mania, excessive energy, etc., speed talking, racing thoughts, but also intermittent periods of depression where you will withdraw, you will isolate, you will stop engaging with human beings, you will spend a lot of time sleeping, etc., right? The idea there that if our measures are valid, then we should be able to consistently tell you this is what's going to happen. This is what's going to happen because you've been diagnosed in this capacity. Finally, we have standardization, which is establishing the requirements for measurement techniques to make sure that it's used consistently across different occasions. The clinical interview gathers information on current and past behaviors, issues, emotions, problems, as well as general life history and any problems they're presenting with. This is the starting point for diagnosis. We gather all of this contextual information so that clinicians have the widest understanding possible of that which is going on in your life that could be contributing to the abnormality of behavior. They also engage in a mental status exam. This is a preliminary test used to determine a person's judgment, orientation to time, place, and to determine their emotional and mental state. The mental status exam covers 5 different areas, and the first is appearance and behavior. You're generally giving just a glance over of the individual coming in, and you're looking for disruptions in motor function, in personal hygiene, etc. Something that would signify something's off with this person. They're physically engaging strangely. It appears that they haven't showered or changed their clothes or washed their clothes in an extended period of time. That's indicative of mental illness. Next, they evaluate the thought process. Is the client's rate of speech extremely slow or fast? Is it confused? Does it make sense? Is their speech disordered? Are they delusional, right? Are they expressing the idea of seeing and hearing things that you as the clinician cannot see and hear? Mood and affect is also evaluated. Determining a client's mood is important to diagnosing possible mental illness. Determining affect, emotional affect, is really important. Is their emotional affect appropriate? Right? So for what I mean by that is emotional affect. If somebody tells you that, you know, a close loved one just dies, what is your emotional reaction? Is it something that we would expect you to experience? Sadness, tears, upset, or is it completely inappropriate? Do you start giggling wildly, right? Do you start singing a song, right? That's determining emotional affect, and to see if it should match the emotional level of the circumstance. And if it doesn't, then we have evaluation again of mental illness. We also want to understand the level of intellectual functioning of the individual. It's just a rough estimate of intelligence, how the memory functions, your level of vocabulary, your comprehension of concepts, so that we can distinguish between mental illness and perhaps a mental disability, because they are a cognitive disability. They're two separate things. Finally, there's sensorium, and this is the level of the individual's awareness of his or her surroundings. Do you know where you are? Do you know what date it is? Do you know who the current president is? This is an idea of getting an idea of, are you here and present mentally, or do you think, you know, we're in 1973, right? All of these things give a clinician an idea of where this individual stands with mental functioning. Okay, if there is a presence of mental illness, the clinician will begin to hypothesize, based off of all this information gathering, what disorder could possibly be present. They will also conduct a physical exam. Okay, if you've recently had a physical, they'll just ask for the information from the doctor. But if it's been a while, which as you get older, it just seems like people really put these off and don't do them for extended periods of time, they will order a physical exam if there hasn't been any recent evaluation, just to make sure all your health diagnostics are okay, right? That there's not something physically that's going on that could be causing the aberrant behavior. They will also conduct a behavioral assessment. This is direct observation of the person in question in order to see them in action and assess their thoughts, their feelings, and their behavior in different contexts. In order to see, is the behavior normal? Is it strange? Is it unusual, etc.? Or is it normal, right? Do they socially engage in a normal capacity? This observation may occur in a naturalistic environment. Naturalistic environment meaning, like, you might go to their workplace and observe them in work. You might observe them at home with their family to see how they engage, right? And to see, again, what the individual's likely diagnosis is. There's also self-monitoring, and this is where the patient or the client observes his or her own behavior and records the information, brings it to the clinician so they can evaluate it. So for example, people who suffer from obsessive compulsive behavior, a therapist might say, okay, for the next week, I want you to write down, I want you to keep track of how many times you wash your hands in a given day. Do you do it more in the morning, the afternoon, the evening? When you're washing your hands, how long do you spend washing your hands? I want you to record this information and bring it to me so I can make an assessment of how severe your compulsions are. Okay, there's also psychological testing. These are just tests that are utilized to assess psychological disorders. So there are projective tests. This is the presentation of ambiguous stimuli to patients to see if their unconscious will respond in a way that helps reveal a disorder. This is based off of Freudian thought processes and theory, right? This is your Rorschach test, where they show you a picture of an ink blot that is a picture of nothing. But the idea that they'll say, what do you see when you look at this? And the idea is that you identify something and they can interpret on the basis of your identification of the image what you're experiencing, feeling. It's sort of supposed to give insight into your possible disorder. There's also personality inventories. These are self-reported questionnaires that assess personality traits by asking questions that describe the individual taking the exam. Very famous personality inventory is the MMPI, the Minnesota Multiphasic Personality Inventory. Myers-Briggs is another one. There's a lot out there, but it gives them an idea of your personality. There's neuropsychological testing, which is the assessment of the brain and the nervous system functioning based on the individual's performance on different behavioral tasks. There's also neuroimaging. These are computer-driven practices such as the EEG or the MRI, which allows examination of the nervous system structure and function. Focuses on two categories. They examine the size and the structure of the brain to determine if anything is damaged or abnormal in structure. It also examines the function of the brain by mapping blood flow and electrical activity to see if there's inadequate electrical activity over here in the brain, or there's too much in this section of the brain, which could be causing the following symptoms. All of this stems from all of the diagnostic tools and procedures come from conducting research. And that's the other thing psychopathologists do, is they conduct research. They continue to study mental illnesses and disorders for improved treatments, right, and a better understanding. All research starts with a hypothesis, and a hypothesis is an educated guess which the researcher is looking to test. So for example, here's a hypothesis. I think depression is caused by low levels of serotonin. That's my hypothesis. We would move on and we would test that, right? We would take a group of people with depression and we would take a group of people without depression and we would measure their serotonin levels. And if the findings came back that the people with depression have lower levels of serotonin than the people without depression, then my hypothesis has been supported. It's got research support. When we're researching, there's always an independent variable and a dependent variable. The independent variable is manipulated by the experimenter in a study, and that's what we are expecting to influence the dependent variable. So in the depression example, the independent variable would be serotonin levels. The dependent variable is the phenomenon that is being measured for change. In the above example, in this example, the dependent variable would be depression, rates of depression. Okay. There's all different kinds of methodology that researchers can engage in. And I'm just going to go briefly through here and define some because you have to have a minimal understanding. So the first is correlational research. And the first thing I always say when I teach correlational research is correlation is not causation. Correlation is a fancy word for there is a relationship. These two variables are related. They could be positively related, they could be negatively related. If they're positively related, what that means is when one of the variables increase, so does the other. When one goes up, they both go up at the same time. If they're negatively correlated, it means when one decreases, the other increases, and vice versa. When this one decreases, this one goes up, right? These are relationships. They are clearly related. There is clearly an impact from one variable to the other. However, you cannot assert causation. And just because variables are related does not mean one causes the other. My favorite example to provide is that there is a strong positive correlation between ice cream sales and shark attacks. Does that mean eating ice cream causes sharks to attack us? Like the sharks can smell the ice cream in our body and they're like, I want the one with the ice cream. No, right? What it means is there's some other third extraneous variable driving that relationship. One doesn't cause the other, one doesn't drive the other. What drives both? It's hot, it's summertime. That's the invisible variable that's causing us to eat ice cream to cool off, right? Or to get into the ocean to cool off. The more we get into the ocean, the greater likelihood we are going to have of a shark attack, right? So those two are both related, but one does not cause the other. So always be careful with correlational research. It doesn't mean that they cause each other or that one drives the other, but it is certainly important to understand that there is a relationship and to try and figure out why they are related. We always strive to obtain causation, right? That's what we really want to get at, is what variable causes what outcome, right? And the best way to get at causation is through a formal experiment, which is the gold standard of methodology. It allows for causation to be determined, specifically because there are two groups. There's the experimental group and there's the control group. Okay, the experimental group will receive the treatment, whatever that is, whether it's drug treatment, therapy, whatever, right? They will get the treatment. The control group gets a placebo, and a placebo is very simply, they think they're getting treatment, but in fact they're not. So for example, when we're testing drug therapies for mental illness, the experimental group will get the new drug, and the control group will get a sugar pill. They think they're receiving, nobody knows who's getting the real drug. So the people who are getting the sugar pill think they're receiving treatment when in fact they're not, right? And then what we do is at the end of the time of the experiment, we measure them. Did we see a difference in the experimental group versus the control group? If the drug works, yeah, we should see a big difference. We should see the experimental group feeling relief of symptomology, whereas we should see the control group maintaining their abnormal behaviors. Right? That is what allows us to get at causation, that we have a comparison group, we have a control group, right? A really good experiment will always match both groups on things like race, age, and gender in order to control for extraneous influences. And this is how we determine the effect, right? This is used in both medical research and social science research. When you have an experiment or research of any kind, you always want strong internal and external validity. If internal or external validity is weak, the findings of the study are limited and therefore not as valuable. So what is internal validity? Internal validity is the extent to which the results of a study can be attributed to the independent variable once we control for other influences. It's that effect. So sticking with our drug treatment example, how much of the outcome of our study has to do with that drug and how much has to do with other variables. This is where matching the groups comes in. If we aren't able to successfully match an experimental group and a control group, and we don't have, it means we're not partially now, we're not controlling the issue of the influence of gender, age, etc. Could be something about gender or age that's driving your outcome if you weren't able to match for it. If you don't have that, then you don't have strong internal validity. Does this mean your findings are worthless? Not necessarily, but it means that you have to exercise caution in how stringently you buy into those findings, right? Yes, we had these findings, however, the internal validity was not very strong, so we need to keep that in mind when we make these assertions. External validity is the extent to which research findings of a given study can be applied to other people outside of the study. You want to have strong external validity, otherwise, what's the point, right? So sticking with our example of drug treatment, this drug treatment study, let's say we found an effect that the people in the experimental group are having far fewer symptoms than the people in the control group. We want to have the ability to say, okay, this is not specific to our experiment and these two groups of people. These findings are going to travel beyond this experiment to the rest of the population of people who suffer from this disorder. We want to be able to go beyond our study. The goal of all research is replication, right? If another researcher took my research study and my methods, they used the same drug treatment, they used an experiment, they used a placebo with the control group, they did everything I did, will they find similar findings? And that's what we hope for. The more studies that repeat the same concept with different participants over time, the more if they find consistent findings, the stronger our findings are, and the closer we are to being able to say this is A is what causes B, and this is how we approach it for treatment. Right? So replication is really important. We want to be able to generalize those findings large scale, not just limited to one study. Once we can do that, that's when we start developing large scale treatments for mental illness and abnormal behaviors.